Welcome back, students. So far, you have seen some terminologies and definitions in pharmacology, and also now you are familiar about some different types of routes of drug administration. Hmm? And the important thing in pharmacology is that when we discuss pharmacology from the first to the last, when we discuss anything about a drug, we will discuss it under two main headings. One is pharmacokinetics and pharmacodynamics. In simple terminology or simple definition, you have seen that the pharmacokinetics means the movement of drug, and the pharmacodynamics means the actions done by the drug. So the pharmacokinetics means what the body does to the drug, and pharmacodynamics means what the drug does to the body. So when we come to pharmacokinetics in detail, we discuss this in under four main headings. They are absorption, distribution, metabolism, and excretion, shortly known as ADME. So in standard textbook and all, they will be referring it as ADME only. They won't write as pharmacokinetics. Instead of that, they write the heading as ADME. So it's understood. Okay, it's the absorption, metabolism, distribution, and elimination. ADME. So today we are discussing about the absorption. So pharmacokinetics, first part, absorption, and the class will be discussed under following headings. There will be an introduction and the details about absorption, and few important terminology or important part of absorption is bioavailability, its clinical significance, and a term bioequivalence, and finally the summary of class. As an introduction, you can see here in the picture, a man is taking a medicine which goes through his intestine and absorption and all thing. Here it is absorbed from the GI tract, distributed to various tissues. Absorption, distribution, metabolism, and finally the excretion. Absorption means how it is get in, so how the drug is absorbed, that means absorption. Distribution means where will it go, so mainly by the transporters it will be moving to different parts, different regions. Then third, metabolism, how it is broken down. So metabolism is the breaking of a drug for making it more suitable for excretion. So metabolism is mainly for excretion, and in few cases there is something indifferent, we will see later. And the main organ of metabolism is the liver. And finally excretion, so the rest of the drug which is not unused or the excess drug will be excreted, and how it leaves. So the pharmacokinetics class will be under these four headings, and the first part we are discussing about absorption. So it is pharmacokinetics is known as ADME. You can see here ADME. That means absorption, distribution, metabolism, and elimination. So what is pharmacokinetics? That means what body does to the drug, or it means the movement of drug into, within the body, into the body, within the body, and outside the body. So movement of drug into the body, within the body, and outside the body. So there is a relation between dose of drug and concentration achieved. So pharmacokinetics will define it has a relation between the dose of drug and the concentration achieved, and it will be discussed under headings like absorption, distribution, metabolism, and excretion. Okay, so absorption. What is absorption? It is the movement of drug from its site of administration into circulation. So it is just it is the movement of drug from the site of administration into the circulation. So in the previous class of routes of administration, you have familiarized some different routes of administration, and the absorption means the movement of drug from that route of administration or site of administration into the circulation, into our circulation, that is into the blood, from site to the blood. Okay, and it depends upon, there are some factors which define the absorption, or factors for absorption. They are lipid solubility, concentration, area of absorbing surface, vascularity of that surface, and the route of drug administration. So all these 5 factors will contribute to the absorption or level of absorption. So how the drugs are transported across the membrane, and in your previous classes, in your +2 classes and all, you have there we have studied that all the biological membranes are lipid bilayers. All our biological membranes in our body are lipid bilayers. That means it is made of lipid. Okay. And how this is passing these membrane? How the drugs will pass these membranes? First of all, by passive diffusion. Passive diffusion means there is the movement of something from according to the concentration gradient. For the higher concentration, it will move to the lower concentration. That is by there is no need of energy needed here. So it is known as passive diffusion. Second, by filtration. So some areas or some membrane there will be some pores, or different size pores will be there. So the movement of particles according to the size of that pores. Then there are some specialized transport mechanisms that will carry a specific type of compound or specific type of molecule one place to another place. That is specialized transporters. Here comes the carrier transporters. So some mediators will carry some material to one place to another. In the movie Transporter, there that guy is, if you have seen the movie Transporter, Jason Statham, he is transporting some things from one place to another. So all movies will be like that. He will be transporting something from one place to another. Like that way, we have got some specialized carrier methods in our body for transporting some materials. So the carrier transport also, there are 2 types. One is facilitated diffusion and one is active transport. Facilitated diffusion means there will be 2 compounds. So the movement of one compound will help for the movement of other compound. That is facilitating. One will be facilitating the another one. So there is no need of energy. The other one is active transport. There we need some energy for transporting one compound. Okay. And now we can see some different locations how the drug is absorbed from that area. In GI tract, it is mainly by passive diffusion. Passive diffusion. And as I've already told, our biological membranes, all of our biological membranes will be lipid layer. So the drugs should be lipid soluble. Then only it can freely move from our GI tract to our cells. So the lipid sheath will be there. So the drug should be lipid soluble and it can pass the membrane. And also it should be in unionized form. When there is no charge, then the substance can be easily absorbed. It will be freely permeable for the membranes are freely permeable for unionized forms. Unionized means there will be no charge, that is positive or negative charge for that substance. For example, aspirin. Aspirin there is not unionized, and also it can it is lipid soluble, so it is freely move through the GI tract. From the parenteral site, parenteral means when we give drugs to our body other than the enteral route. It is the parenteral route, mainly the intravenous. Intravenous means we are directly injecting our drug to the blood circulation. So the main principle of absorption is movement of drug from the site of absorption to the blood. So here the intravenous administration, we are directly injecting to the intravenous system or the blood. So it will be the complete and the rapid method of drug administration. And when we are giving other injections like intramuscular and subcutaneous, it will be absorbed through the blood vessels. So intramuscular is more when compared to subcutaneous. Intramuscular means the muscles will be having more blood supply than the subcutaneous tissue. So that's why when we are giving intramuscular, from there it will be more absorbed. Here also mainly the passive diffusion and the high vascularity than subcutaneous. That's why intramuscular region has got the more absorption than subcutaneous tissue. Now an important route is lung. So in the gaseous form, when we are giving general anesthesia or some other type of drugs, the absorption here also it is mainly simple diffusion. That's from the higher concentration it will goes to the lower concentration. Here also the absorption is rapid. Okay, And the important feature is that when we compare the lung to other, there is a large surface area for the lung, so a large amount of drugs can be absorbed very fastly, and also highly vascular. Our vascularity is very high in the lung, so the absorption will be very rapid. On the topical sites, so when we are applying on intact skin, the absorption is very poor. When we are applying on intact skin, the absorption is poor. And in dermis, intradermis and all, permeable to lipid soluble drugs. So the dermis, here you can see in the picture, you can see the skin and different layers of skin, epidermis, dermis and subcutaneous tissue and all. Here the intact skin will not be permeable for most of the substances, and the dermis, the layer dermis will be permeable to lipid soluble drugs only. So only a few amount of drugs can be directly absorbed from our skin, and it should be lipid soluble. Only then we can cross this dermis. You can see the blood vessels are mainly in the subcutaneous tissue, so it has to be crossed this dermis to reach the subcutaneous tissue, and the dermis is permeable to only the lipid soluble drugs. Okay. And now the important term, bioavailability. It is the fractional extent to which an administered dose of the drug reaches its site of action, or a biological fluid from which the drug has access to its site of action. It is the fraction of unchanged drug reaching the systemic circulation following administration through any route. Okay. So our basic principle is movement of the drug from site of absorption to our circulation or to our blood vessels. So during that transportation from the site of absorption to the blood vessels, there will be different process will be occurring, and the fraction of unchanged drug reaching the systemic circulation is known as the bioavailability. So how much amount of the drug is reaching in blood or in circulation after administering in any route of administration is known as the bioavailability. So when we are giving intravenous, we are directly injecting that drug to that blood system, so we will get a 100% bioavailability. Okay, 100% of bioavailability. We can calculate by the bioavailability is denoted as F. So bioavailability is equal to quantity of drug reaching systemic circulation divided by quantity of drug administered. Okay, so it will be in percentage. Now the components of bioavailability. Mainly there is two components. One is rate of availability and extent of availability. Okay, rate of availability and extent of availability. See, here the x-axis is about plasma concentration and y-axis is about time. Okay, so one drug, we are administering one drug, and it in any route, consider there is no route mentioned here, so consider it's some through oral route or something else. Here the drug is absorbing slowly, so the plasma concentration is increasing, and some time it reaches the maximum, so the plasma concentration becomes the maximum at some time, then it gradually decreases, so the absorption will be decreased, or the absorbed drug will be eliminated, or the mechanisms or some actions will be happening, and the concentration of that drug will be reduced gradually. So the Tmax and Cmax measures the rate of availability. So the Tmax means where the concentration is highest, so Cmax and Tmax are related. It measures the rate of availability, and the total area under this curve, defines the extent of bioavailability. So the total area under this curve will shows the extent, so how much amount of drug is absorbed. So we can calculate how much amount of drug is absorbed by this area. So this is the total amount of drug absorbed, and the Cmax and Tmax is the rate, what is the speed. Okay, how fast this is absorbed we can define from Tmax and Cmax. Again here is the plasma level and here is the time. So for the oral route, initially it has to be reached in our intestine. From there only absorption start. So starting from here, slowly absorption increases. Some place there will be the maximum amount in the blood, and the concentration will gradually decreases in the blood, because that some will be excreted or some will be gone for some other places, some will be transported for some other places. So the concentration will gradually decreases. And when we are giving IV, you can see this is IV and this is oral. When we are giving IV, at the time itself, it is at the maximum. At the time of administration itself, it is the maximum amount in the blood vessels. So the maximum, then later it will be distributed to some places, some will be metabolized, some will be excreted. So gradually this graph will come down. Okay, so the difference, you can understand the difference of oral and IV from the figure itself. So bioavailability, and also we can compare bioavailability of a drug. Here we are determining the bioavailability of ampicillin. One is given as IV and one is given as oral. So to find the bioavailability of ampicillin, we can find the AUC, that is area under the curve of oral divided by area under the curve by IV into 100. This gives the bioavailability of ampicillin. For every drug we can calculate by this way method. And in detail, bioavailability will be dependent on two factors. One is pharmaceutical factors, other one is pharmacological factors. So what is pharmaceutical factors? It is the disintegration and dissolution, degree of ionization, particle size, salt form and crystal form. So these all are pharmaceutical factors. So these all factors are determined by when we prepare a drug, its disintegration, dissolution, degree of ionization, particle size, salt form or crystal form, and also water of hydration and nature of excipient and adjuvant. So all these 8 factors contribute to the pharmaceutical factors of bioavailability. Formulation of the drug. So when it is in oral preparation, it has to be disintegrated. So when we take a tablet orally in the stomach, it has to be disintegrated. It should be break down into small particles or to be made to fine particles. Then it has to be dissolved. So it will be it has to be made in a liquid form, and only we can absorb from the intestine. So drug into solution. Then it will be absorbed from our GIT. When we talk the example, we are giving the oral, consider it is a tablet or a capsule. So it has to be break into small particles in the stomach. Okay, and it takes time. Then it forms the fine particle, then should be dissolved, and the absorption. So it takes that much time. So instead of that, when we are using powder or suspension, it's already in a fine particle form. So we can avoid the first step, disintegration. Then only we need dissolution, then the absorption. Again, when we are using solutions, they will be directly absorbing into a GIT. Okay, so the absorption will be, the solution will be having high absorption or fast absorption, then the suspension, then the capsule, then the tablet, then the enteric tablet, and slow releasing tablet. Okay, this is the descending order of absorption. So the solutions will be having high or the fast absorption, and the slow releasing tablets will be having slow absorption. Next is particle size. So when the particle size is reduced, or when it is the fine particle, the bioavailability will be increased. Okay, so the microfine aspirin, spironolactone, griseofulvin, digoxin, these all are made into small particles or fine particles, and only we can increase the absorption. Salt form. Here the weakly acidic drugs, they will be highly water soluble. Okay, highly water soluble means it will increases the bioavailability, tolbutamide, sodium or phenytoin, sodium and all. So the weakly acidic drugs, they will be highly water soluble and they will be easily absorbed from our stomach, which is an acidic medium. And according to the excipient and adjuvants, excipient and adjuvant means some substance which are added to these drugs to make a form. To making a tablet and all, we have to compress that particles to make a tablet. For that we use some materials to compress that tablet, like starch, gum, calcium sulfate, lactulose and all. These all are increases the bioavailability, like phenytoin, digoxin, levodopa or warfarin and all will be added to these substances will be added to these drugs to increase the availability. Next is degree of ionization. The thing I have already told, our lipid layers, lipid bilayer, when the drug is unionized form, it will be easily absorbed. So unionized lipid soluble drugs are better absorbed from our biological membrane. Pharmacological factors. First pass metabolism, route of administration, gastric emptying or gastrointestinal motility, food, drug interactions, pharmacogenetic factors and miscellaneous factors. So these all are come under pharmacological factors for drug absorption. First pass metabolism. So what is first pass metabolism? It is the metabolism of a drug during its passage from site of absorption into systemic circulation. Okay, so the absorption means it is the movement of drug from the site of absorption to our vascular circulation. So while going from while absorbing from the site of absorption to the circulation, it has to cause many membranes and many organs and all. So during that pathway or during that passage, the drug get metabolized. This is known as the first pass metabolism. So the drugs like benzyl, penicillin, insulin will be metabolized very freely metabolized or very fastly metabolized through our gut lumen. So we can't give this benzyl, penicillin or insulin orally. Okay. Tyraminol, they will be absorbed or metabolized in the gut wall. And next, the important organ for metabolism is liver. Majority of drugs which are given orally will have to cross the liver. So liver will metabolize whatever it comes to your liver, it will be metabolized. So liver can metabolize propranolol, lignocainol before reaching systemic circulation. So these all drugs are they are very less given as oral route, or instead the benzyl, penicillin, insulin, thiamine are not given orally. Propranolol, lignocaine can be given, but very large amount. Propranolol has to be given large amount to reach the systemic circulation. So the first pass metabolism will decreases the bioavailability of drugs. Now here you can see when the drug is absorbed from the site of absorption. So it takes the absorption. The drugs will few will go to the feces, some will go for metabolism, and some will has to go to our blood circulation. So while going to blood circulation, it has to cross the liver. So some amount will be lost, and the rest is known as bioavailability. So this is different drugs having different first pass metabolism. Here you can see some has got high first pass metabolism and not given orally: isoprenaline, lignocaine, hydrocortisone, testosterone. Some drugs which are given orally and having high metabolism, high first pass metabolism, high dose have to be given orally: propranolol, hyperenol, verapamil and all, salbutamol and all. We have to be given high dose when we are giving orally. Okay, some drugs having low first pass metabolism, even though they are given orally, there will be low first pass metabolism. Now we can see the concentrations of different route of administration. Okay. First, the intravenous method. Intravenous method, when we are the time itself will be high, maximum concentration in our blood, and gradually decreases. Okay, you can see this. Intramuscular, there will be gradual increase and later gradually decreases. Subcutaneous, this blue color, the absorption is slow when compared to some muscular. The absorption is slow, and a steady state will be reached, then gradually decreases. And finally orally, it takes so much time for absorption, and also it slowly will be reduces the concentration. Okay, so this black line denotes the therapeutic concentration. So this has to be reached for therapeutic action. Okay, all of them reaches the therapeutic above the therapeutic level. So all of them will be giving therapeutic clinical therapeutics. Next factor is gastric emptying. Increased gastric emptying enhances bioavailability. So the most of the drugs will be absorbed in our intestine. So the faster the contents are moved to intestine, the faster will be the absorption. And also bioavailability will be increased during fasting, anxiety, lying on right side, hyperthyroidism, drug like metoclopramide. So the example is metoclopramide. It will be more absorbed when there is fasting and anxiety, lying in the right side, or hyperthyroidism. And also bioavailability will be decreased with the fatty meals, depression, lying in left side, pyloric stenosis, hypothyroidism. Drugs like atropine, imipramine and all will be having this type of reactions. Some disease states. So when we are giving the drug orally, they has to be crossed different region. So if there is any disease, gastroenteritis, celiac diseases, Crohn's disease, congestive heart failure, liver failure disease and all, the absorption will be affected. And food drug interaction, when there is food, absorption is increased in empty stomach. So rifampicin all are given in empty stomach. Absorption increased after meal. The drugs like lithium phenytoin and all, which is given after meal. Absorption of tetracycline decreases if taken with the milk because it will form some complexes. Vitamin C keeps iron in ferrous form and increases the bioavailability. So when we are giving iron tablets for a pregnant women and all, we always give with a vitamin C compound. Or in citrus fruit, we usually give the iron tablets with the citrus juice and all. Okay, the clinicians usually give through with the citrus juice. And drug interaction. So two drugs will be having interactions. For example, when antacid is used along with the tetracycline. Antacid decreases the bioavailability of tetracycline by forming poorly absorbed chelating complex. So tetracycline and antacid is given simultaneously or same time. The tetracycline will combine with antacids and form some complexes which will not be absorbed. So it will reduces the efficacy of our tetracycline. Phenobarbital, phenytoin, rifampicin all decreases bioavailability of drugs like enzyme induction. Okay. Again, there is some important thing: enzyme induction and enzyme inhibition. One will increases the metabolism, one will decreases the metabolism of these enzymes. Enzymes are present in our liver. So these enzymes, liver enzymes, are very essential for metabolism of some drugs. So some drugs will inhibit this metabolism, some drugs will increases the metabolism. Induction means increasing. So phenobarbital, phenytoin, rifampicin all are increases the metabolism by enzymes in the liver. So it will decreases the bioavailability of some other drugs. Again, the INH means rifampicin, isoniazid, cimetidine will increases the bioavailability by enzyme inhibition. They will inhibit the metabolism of some other drugs and it will increases the bioavailability. Then pharmacogenetic factors. Pharmacogenetics means there are some genetic relation with some pharmacological actions. Some metabolism, during metabolism there are different steps for metabolism. One of the important step is acetylation, and important drugs like isoniazid, PAS all are metabolized by acetylation. Isoniazid is an important drug used in tuberculosis. So some people, they will be slow acetylators. That means it has got an increased bioavailability. So the drug will be slowly metabolized in the body. So we will get so many time, the drug will be there in our body for so much time and the absorption will be increased. And in some cases, some people, there will be atypical pseudocholinesterase. It is an enzyme which will hydrolyzes the succinylcholine, some type of drug used for anesthesia. So some patients having atypical pseudocholinesterase decreases the hydrolysis of succinylcholine, which increases the bioavailability of succinylcholine, which leads to succinylcholine toxicity. So these all are factors. The increased bioavailability of some drugs are toxic to our body. And there are some miscellaneous factors also, like area of absorbing surface, state of circulation of the site of absorption, and all are different factors. Now the clinical significance of this absorption. A drug with low bioavailability is given as parenteral dose or at high oral dose. Okay, drugs with low availability bioavailability. So when the drug we are given having low availability means the oral dose will be oral absorption will be very low, or when we are given in oral route the absorption will be very low. So at that time we can use parenteral route. or if the parenteral route is difficult, we will have to give high dose orally. Okay, then only we will attain a certain concentration of that drug. And another important thing is different formulations of same drug may have different bioavailability. So the different formulations, if the drug is given, if these drugs like lithium, theophylline, nifedipine, diltiazem and all, when they are given in different routes, different method, sometimes when you are giving it as oral route, same is given as IV route and all, they will be having different bioavailability. And drugs with narrow margin of safety. Here also we should be very cautious when we are using different routes of administration. Narrow margin means the margin of safety and toxicity will be very small. So a slight change or slight increase from the safety margin itself will cause toxicity. The drugs like digoxin, tetracycline, chloramphenicol. So we should be very cautious when we are using these type of drugs. And some drugs like will have steep dose response relationship. Okay, the dose response relationship, when the dose response relationship is in a steep pattern, also we should be very cautious. The drugs like phenytoin, phenylbutazone all have a steep dose response relationship. Here all we need precise dosage control. So these situations, these two situations, we need precise dose control. Okay. So for that we have to check the blood levels every time when we give the drug and analyze the concentration of drug in our blood. Okay, that is known as therapeutic drug monitoring. Now a term called bioequivalence. That means if two or more similar dosage form of a same drug reach the systemic circulation at the same relative rate and same relative extent. So if two or more similar dosage forms of the same drug, then it is known as bioequivalent. So different of less than 25% difference has have no considered significance. So that means when a drug, when two drugs, one same drug, when considered drug A is produced by two companies. Okay. By X and Y. So there is a two company called X and Y producing same drug A. They are making same drug A with different names. When maybe you can consider A1 and the X company is making A2. But when we take these both drugs A1 and A2, when we measure the bioavailability or the time or extent which reaches the blood circulation is same. So it is said that this A1 and A2 which is produced by different countries like X and Y are bioequivalent. Okay. So consider that there is two companies X and Y. They are producing a same drug A. One is producing A1, the other one is producing A2. This is the same compound. So when we measure the bioavailability, we have seen that both A1 and A2 has got same extent and same rate of absorption. That means this is called bioequivalent. They are bioequivalents. And the difference, when the difference of absorption of A1 and A2 is less than 25%, when we calculate, and it is less than 25% means also there is no significance difference, or even 25% of difference can be considered negligible. Okay. Now chemical equivalence, if two or more dosage forms of same drug contain the same labeled quantities of drug as specified in pharmacopoeia, like different brand of phenytoin, same way, same that a company, you can call two companies X and Y, they are producing a drug phenytoin. Phenytoin is the parent compound, so they are producing a phenytoin A1, other one is producing phenytoin A2. When we check the pharmacopoeia, both have same chemical concentrations or the dosage forms contain the label quantities, so they are known as chemically equivalent or chemical equivalents. Therapeutic equivalence, when two brands of product of one drug, again here consider two brands, they have identical in vivo pharmacological response as measured by control of symptoms of disease. Here also, when two companies X and Y are producing, consider phenytoin, they are producing phenytoin A1, other one is producing phenytoin A2. Both has got identical in vivo pharmaceutical response and also the clinical response. This is known as therapeutical equivalence. If they are having, both of them have some same therapeutic measures or therapeutic change, then it is known as therapeutic equivalent. And finally, the summary of our class. The pharmacokinetics means what the body does to the drug. So the pharmacokinetics will be discussed under 4 main headings: absorption, distribution, metabolism and elimination. Okay, absorption means how it will be get in our blood circulation. Distribution means where these drugs are moving through the transporters. Metabolism means where or how this drug is broken down. And finally, excretion means the leftover drug or the unchanged drug, how it is eliminated from our body. And when we consider the absorption, it is the absorption of a drug from the site of absorption to the systemic circulation. Site of absorption to the systemic circulation. So there are different factors which affect this absorption, and when we consider a drug, we can find the rate and extent by a term bioavailability. So we can find out the bioavailability of a drug by calculating the area under the curve of IV and area under curve by oral. So here you can see the area under curve by oral and area under the curve by IV. So the bioavailability will be area under the curve by oral divided by area under the curve by IV. So this is the method of finding bioavailability. And also about first pass metabolism, it is the metabolism of the drug before it reaches the site, before it reaches the circulation. So every drug absorption means from the site to the circulation. So during this passage or during the movement, some drug get metabolized. This is known as first pass metabolism. And the main organ in our body where metabolism is occurring is the liver. Okay. So now we will stop here the absorption. The further discussion of next topic will be in the next class. So please go through the presentation, and also you should read the concerned topic in the textbook. Kindly use the standard textbook and go through the textbook. If you met with some doubts, you can text any faculty of the department, or even you can text in the Google Classroom. So if there is any doubt, you can contact us. We will be there for your help. So, and once again, thank you. Stay home, stay safe. Thank you, Dr. Rahul.